So let's look at the grant study into opiate antagonists. So opiate antagonists had already been found in several previous studies to be effective for some people when treating pathological gambling. But 10 to 30% of people still showed no significant improvement. So the central aim of this particular study was to try to understand why. What were the clinical variables that would be associated with a successful treatment using opiate antagonists? This is important because, of course, the more quickly you can get people onto a drug that will actually work for them, the less time they spend taking drugs that will not work for them, the sooner that they will be able to get better. Opiate antagonists had already been used to treat substance abuse. Specifically, it was used for cocaine, alcohol, what else? Heroin, I knew I forgot one. It had already been used for those. And the way that it worked when it was treating substance abuse was that it would reduce the reward center's response. So the idea of an antagonist is it blocks. So it would block the opioid receptors in your brain so that you would have less of a positive reward response. And as a result of that, you would feel less of an urge to engage in that addictive behavior. I know that when you think of opioid, you probably think of like drugs on the street, but we have natural opioid receptors in our brain. So that's what's happening here is the antagonists are blocking them and preventing those neurotransmitters from being absorbed, that rush of dopamine, because again, dopamine is in our reward center. It prevents the dopamine from being absorbed in that opioid receptor, and therefore you don't get that rush. It has, like I said, already been proven effective for alcohol dependence, and one of the main predictors of whether it would work to help people to cure alcohol dependence was whether people had a family history of alcoholism. So you can probably see where this is going. So that was one of their hypotheses, was that a family history of alcoholism would also predict that you would respond well to opiate antagonists for pathological gambling. They also found that stronger cravings of alcohol or stronger cravings for alcohol were also a predictor that you would respond better in the earlier studies of using opiate antagonists to treat alcoholism. Alcohol dependence is genetically linked to pathological gambling. It also is like has similar, what they call it. They said it had genetic and phenomenological links to pathological gambling. Alcohol dependence does, and they often occur alongside each other. So that's where the basis for this study in particular comes from. I will tell you that here is how it's described in the study. The efficacy of opiate antagonists in the treatment of addictive disorders has been proposed to involve opioidergic modulation of mesolimbic dopamine circuitry. Great. So we know what dopamine is. We can figure out that circuitry is like brain circuits. The mesolimbic pathway is a pathway in your brain that connects your ventral tegmental area. You may have heard this, and I think we mentioned it a couple times, the VTA. It connects one part of the brain to another. Like I said, the VTA, and it connects it to the nucleus accumbens. Both of those are related to the brain's reward center, or reward system. You know the term striatum as another, like being part of that reward center. One thing about the mesolimbic pathway is that often drugs, like illegal drugs, can hijack that pathway, and as a result, it can be the result of causing strong cravings for those illegal drugs. But that's just so opioidergic modulation means making changes to the opioid receptors in the brain. So like I said, blocking them, making them less likely to absorb that dopamine and not giving you that strong rush. So like I said, the aim is to identify clinical variables associated with a positive treatment outcome. There were two hypotheses. One of them was that a family history of alcoholism would be associated with positive outcomes and stronger urges to gamble. Because as you recall, stronger alcohol cravings were associated with a positive outcome. So stronger urges to gamble would be associated with a positive outcome. This was a double-blind placebo-controlled study. So people with less severe pathological gambling, it was hypothesized, would be more likely to respond positively to a placebo than those with severe pathological gambling. So that kind of makes sense. If anyone's going to have a placebo effect and improve despite not receiving any real active medication at all, the hypothesis was that it would be people who had less severe PG. To talk about your sample, so we know we had 284 participants that had pathological gambling. They were 48% female, so a roughly even gender split. They had to score at least a 5 on the SOGS, the South Oaks gambling screen, and they had to have reported gambling within 2 weeks of enrollment in the study. There were some pretty important exclusion criteria. I could definitely see them asking about these. Women had to be not pregnant, so the exclusion criteria would be pregnant, or if you were not on birth control. You had to prove that you had regular use of, they said an exclusion criteria was inadequate contraception. They wanted to make sure, because drugs like this can have effects on developing fetuses, they're always quite careful when it comes to trials of drugs to make sure we're not including women that are pregnant or could become so. They also excluded people who were infrequent gamblers, less than once a week, meant they didn't meet the DSM criteria. Anyone with a lifetime history of any of those disorders. If they needed medications that had psychotropic effects, those are meds that affect your brain and behavior. Or if they needed drugs that had unfavorable reactions with opiate antagonists, that would be an exclusion criteria. Current substance abuse or dependence other than nicotine. So if you were, because we talked about the interactions with, the history of using this to treat drug addiction, they wanted to exclude anyone who was currently dealing with substance abuse. They also, if you had a positive drug test during the screening, you would have been excluded. Anyone who had started psychotherapy or behavior therapy within 3 months prior to the study would be excluded, which makes sense, because if your goal is to test the effectiveness of this opiate antagonist for particular groups of people, you wouldn't want people who had also just started another therapy, because you wouldn't be able to conclude that they were improving as a result of the opiate antagonist. Anyone with an unstable medical illness or a clinically significant abnormality on their lab test or EKG or during their physical examination, all of those were grounds for the exclusion criteria. There's a couple that I didn't put on this page. Clinically significant suicidality, they excluded people. Previous treatment with nalmefene or naltrexone obviously would make sense. You would want to exclude those people. Treatment with any other investigational medicine or fluoxetine. Fluoxetine is an antidepressant that's also used to treat impulse control disorders. So they made sure to exclude people that met any of those criteria. Then, of course, they were assigned to groups. So what's actually going on here is it's 2 separate double-blind placebo clinical trials, one that's 16 weeks and one that is 18 weeks. You may remember that one of them was taking place, there was the multi-center 16-week study of nalmefene. So that was the one where people were, that is the nalmefene trial is the 16-week multi-center one, and then the University of Minnesota one is the 18-week naltrexone study. They were all from the United States. Obviously, it used an independent measures design, and everyone was randomly allocated to one of these conditions. Everyone was 1/4 of people were assigned to a placebo group, and the other 75% were assigned to an active medication. You can see the dosages there for the naltrexone. 1/4 of the people in the University of Minnesota trial were assigned to a placebo, and then 1/4 received 20, 50, and 100 milligrams. And then for the other one, 1/4 received a placebo, and then either 50, 100, or 150 milligrams of nalmefene. When they were collecting data, these are some of the measures they used. They used a structured clinical interview. First off, to assess psychiatric comorbidity. You have a comorbidity if you have 2 illnesses at once. So if you have for example, a heart condition as well as diabetes, you'd call those comorbidities. Psychiatrically, obviously, we would be looking for you to have another psychiatric disorder in addition to pathological gambling. And depending on the severity of that, you might have been excluded. They excluded people with schizophrenia. They have their list of things that they excluded. Schizophrenia, dementia, bipolar, or any psychotic disorder. So first they wanted to assess that. They also had them do a semi-structured rater-administered questionnaire. So they use the PGY box to collect information. The PGY box the Y box that is a variation, because of course, Y box is obsessive compulsive scale, but there's a variation of it used to assess pathological gambling. So remember, this is partially a questionnaire, but you're being asked the questions by the rater, the person who is conducting it. And then they also are able to ask follow-up questions. They also obviously needed to ask questions about family history. In this case, particularly as it related to whether you had first-degree relatives with either psychiatric disorders. They asked about psychiatric disorders, and they also asked about alcoholism. The term they use is probans. They did interviews of the probans. The proban is just the first person in a genetic study like this. So the root person that you are talking to, and then they ask them about each first-degree relative's history of psychiatric disorders or having at least one first-degree relative with alcoholism. That's how they defined a positive family history. So at least one first-degree relative with alcoholism. In addition to this, they had them do some other stuff. They had them take the Sheehan Disability Scale, which is 3 items, and it's a self-report scale that is an assessment of your psychosocial functioning. I'll show it to you. I can't remember if this is the only time we encountered this, but just a brief patient-rated measure of disability and impairment. So this is not unique to pathological gambling or any particular disorder. Like we said, it's a measure of psychosocial functioning. So the extent to which we talked about significant impairment. So you can see, as it relates to work and school, have these symptoms disrupted your work or schoolwork on a 1 to 10 scale? How has this affected your social life? And how has this affected your family life and home responsibilities? And then they ask about days that you lost as a result of the disorder. But again, they use this. They administered this each time the participant came in. And you can see how this would be a good quick check-in. They also gave them the Hamilton Anxiety Rating Scale, which is administered by clinicians to assess your anxiety. And they also gave them the Hamilton Depression Rating Scale. It's called the HAM-A and the HAM-D. The HAM-A is for anxiety. The HAM-D is for depression. That is a 24-item clinician administered rating scale assessing the severity of depression. So just to also keep track of their anxiety and their depression, because you're going to see that one of the things they were looking at was, because remember, we're looking for what are the clinical variables that suggest you will have a positive treatment outcome with opiate antagonists. So those are some variables they wanted to make sure and measure and see if those might affect people's reactions to the drug. So they needed a definition of positive response or successful treatment, and that was defined as at least a 35% reduction in their PGY box score for at least 1 month before the end of the study. The PGY box assesses both your thoughts about gambling as well as your behavior. It has sections for both, and they make a point of saying that they weighted them equally. And the defining treatment response this way has been found to correlate with clinically significant changes in PG. So it's not just whether your urges changed or your behavior changed, it's both. They looked at a lot of variables. I'm actually going to start by telling you some variables that did not prove to be significant. One of the ones they looked at was the type of gambling that the subjects did. 48% of them 48% of the subjects played non-strategic games only, so like slots, bingo, lottery. 15% of them played only strategic games like blackjack and poker, and then 36% of them played both. Type of gambling activity was not associated with response. So it didn't matter which type of gambling you did, that was not associated with whether or not you responded to opioid antagonists. Despite the fact that they excluded people with substance abuse and schizophrenia and bipolar, they did still have people in the study with some clinically important co-occurring disorders. 24% of them had met the criteria for mood disorders like major depressive disorder, anxiety disorders, panic disorders, and eating disorders. So all of those, there were groups with all of those things. There were also 42% of them used tobacco. But neither the co-occurring disorders or the tobacco, neither of those was associated with a treatment response. So they eliminated something by asking about those things in the clinical interview. They were able to eliminate some things as possibilities. The analyses they did provided similar results between the nalmefene and the naltrexone group. So they ended up combining the data so that they would have, what did they say? So that it would have increased power, statistical power. So they ended up combining them because there wasn't a substantial difference. Far and away, a family history of alcoholism had the most robust association with positive treatment response to opiate antagonists. There was no other variable that was statistically significant for the entire sample. One thing they found was that baseline urges to gamble were not predictive. You may remember that they had predicted that people with stronger urges to gamble would respond more positively because people who had stronger cravings for alcohol responded more positively. But in the whole sample, that was not true. They did find that stronger urges to gamble were correlated with a positive treatment response, but only amongst people who were receiving the higher dose. Now, when they looked at the placebo group, you may remember they had expected that those with less severe pathological gambling would respond more positively to the placebo. That was not what they found to be true. They found actually no variable was clinically significant at a certain level, but the one that was most associated with having a positive response to the placebo was age. The younger you were, the more likely you were to respond to have a placebo effect, to improve from the placebo. They found that for each age increase of 10 years, subjects were approximately 30% less likely to respond to the placebo. Part of that part of that they theorized was that for younger people, those learned behaviors were less deeply ingrained, so you were more likely to be able to you were more likely to respond to the drug. In the discussion, Grant talks a little bit more about the placebo response and says how important it is to consider it because there's often a placebo response observed in these controlled trials of PG. Two theories that they offered for why remember their hypothesis was milder PG would yield a placebo response. They offered two theories as to why that might not be true. For one, you had to be fairly have fairly moderately severe PG to even get into the study. So they acknowledged that kind of limits the range of severity because the severity ranged from like moderate to severe. They also acknowledged that because there were only 4 arms in the trial, 4 conditions per trial, 3 of them were medication, the actual number of subjects that were taking a placebo was comparatively small. Only 70 of the 284 subjects were actually assigned to a placebo. Also in that discussion, Grant mentions that the differential treatment response may reflect individual biological differences, such as those associated with opiate antagonist response in alcohol-dependent subjects. So, for example, they have found that amongst people with alcohol dependence, there is a gene variant, an allelic variant of a particular gene, the mu opioid receptor gene. So this is the gene that encodes for the creation of these opioid receptors, and that particular variant has been associated with having a positive treatment response to naltrexone in alcohol dependence. So one question for further investigation is, does that extend to subjects with pathological gambling? In case you hadn't figured it out, a lot of the discussion section is always like, something else you should investigate is this. The reason this is important is, I'll read you a sentence from it. Nonetheless, the study suggests that readily attainable clinical information can be used to guide pharmacotherapy selection for PG. So through a simple clinical interview like this, we can probably get enough information that can help us to make a more informed choice when we're selecting which drug for people with PG to take. They've also been using mood stabilizers and SSRIs. So if we can figure out which clinical variables suggest that you'll respond well to PGs versus something else, we can set you up with the correct drug the first time around. Another phrase they use, which I like, is this information can help to generate treatment algorithms. You may remember that flow chart we looked at for schizophrenia that was like, first this. If that doesn't work, then this. If that doesn't work, then first typical, then first atypical, and then this group of drugs, then this one, and then they're like, then try clozapine, because clozapine has some pretty serious side effects. Here we go. I figure we'll just look at it. Stage 1 is a single second generation antipsychotic, so atypical. If you don't respond to that, then a different one that wasn't tried in stage 1, then clozapine. Clozapine can have serious blood pressure issues and also like slow your heart rate. So that's why it's like a stage 3. If you don't respond to clozapine, then clozapine plus something else, and you can see there ECT is. If you don't respond to that, then we're throwing everything at you. So this is a treatment algorithm, and if we can figure out which clinical variables will cause you to respond to PGs, then instead of just trying a bunch of different things, we can get you to the right drug quicker. And remember that because impulse control disorders are learned, at least some portion of them is certainly learned or reinforced by our operant conditioning. The sooner we can get people treatment, the less likely that those behaviors will become more deeply ingrained. Then I'll let you just look at this, and hopefully that helped you remember the key points of GRANT.